Here's the new Chirotouch program for my chiropractic office. So I'm going to take a test patient and I'm going to open them up, and let me just go over the daily notes, and let me just go ahead and delete everything so we can start fresh. We're going to delete this note, just as simple as that. We're going to say his chart note is that he is here for an initial exam. He has chief complaints that started today. He is here for an examination, a chiropractic manipulation, and physical therapy. We're going to then say that his chief complaints are a first complaint of, let's say we give him some neck pain, and we're going to say that we're going to rate that about a 4, and that he's having this about once per week, and that is going into the right shoulder. There is no stiffness associated with this, and let's go ahead and give him a second complaint of, let's say we're going to give him low back pain. So we're going to say his low back pain is rated about a 1, and he's having this 4 days a week, and that it does go into the right gluteal region. There is stiffness associated with that, and we can say that this condition is aggravated. Let's go over here. We're going to say that the aggravating factors does standing aggravate. Standing aggravates the, let's say it aggravates the low back, and that standing aggravates the low back after about 20 minutes. We're going to say that walking does not cause any aggravating factors, and we're also going to say that sitting causes pain in the low back after about 30 minutes, and that there is no aggravating factors with bending. We're not going to add any additional comments about it right now, and we're going to come out of here. We're going to add some spaces, say that palliative factors, it feels better with rest, sleep, and Advil, and that there's no other information we're going to give to it. The etiology, we're going to say it began, his pains began about a month ago, and that they're unknown, and we're not going to say when he first noticed it. It's not a car accident. We're not going to give work-related status, and then we're going to say that his past medical history. He denies having any broken bones, denies having any surgeries, and denies having any past medical traumas. It's not a female, so we're not going to say how many kids they've given birth to. The patient does not have a pacemaker. The patient does not have diabetes. From there, general health history. They have a family history of general health history of asthma. They have had a heart attack, and this is not a gravid female. The patient has a family history of stroke and cancer, and from there we're going to say that the medication list, the patient is going to be asked to bring in a list of all their medications. We have it on file. We're going to say the person is a day smoker, smokes every day. From there, we're going to get out of the chief complaints. We're going to go under the objective findings. For the examination, presenting with a gait. He has a right antalgic gait today. We're going to say that his vital signs. We're going to take the vitals. We're going to say his height is 5 foot 9 inches. He weighs 180 pounds. We got this from a scale. We're also going to say that his blood pressure is 120/90, and that his pulse rate was 80 beats per minute, and that his temperature through the ear was 98, and we'll go back for his respiratory rate. His respiratory rate was 14 breaths per minute. Was non-labored breathing. From there, we're going to go out of the vitals and we do the review of systems. The patient review system is going to be detailed. We're going to say this person has myopia and that they have a decreased hearing in their right ear, decreased sense of smell, they have acid reflux, has constipation, does not have any breathing problems. We're going to say he does not have any chest pains. He does not have any skin irritation, so we're going to skip where the irritations were. It's a male, so we're going to say nothing about the mammogram. Has had a recent PSA. The PSA was normal. And then from there, we're going to get out of the review of systems and go over orthopedics. We're going to introduce the orthopedics as being done for his complaints of cervical. We're going to say foramen compression was negative, cervical distraction was negative, shoulder depressor was positive on the left, and it was positive on the left upper neck and to the left shoulder. We're going to get out of our orthopedics for the cervical. We're going to briefly do some lumbar orthopedics, Adams was negative, Miners was negative, and we'll say that Eli's was positive on the left also. And let's get out of this. And then we're going to go under reflexes. We did upper and lower reflexes. They were all normal. So we're going to get out of reflexes, and then we're going to go under visual range of motion. We're going to say that we're going to do visual range of motion, and the cervical range of motion was normal. However, there was pain with flexion. And for the lumbar range of motion, let's go ahead and say that for lumbar range of motion, there was restriction. It was mildly restriction on flexion, mildly on extension, severe right restriction, severe left lateral flexion, and there was no pain associated with this, ironically. We're going to skip that, go visual range of motion. This person, I do not take, let's go under palpation findings. We're going to introduce the palpation findings, that he has tenderness at the following levels. We'll call it C1, C2, L4, L5, and the right hip. There is muscle spasms associated with the neck, upper back, and the low back, and that he has subluxations at C1, C2, L4, 5, and at the right sacrum. There was no edema noted. Let's get out of here. This person's on a plan that I do not take x-rays on, so he has not had recent x-rays, and we're going to say that he will be sent out for x-rays, 4 view of the neck, and 2 to 3 view of the low back. And from there we are done with here. We're going to come to our assessment of this individual. We're going to do an examination assessment. We're going to say that he has a diagnosis of, let's say, subluxations at C1 and C2, L5 sacrum, and the right hip, and these subluxations are associated with the diagnoses of neck pain and low back pain, and let's go ahead and find some sciatica involved in that also. It's not related to a sprain strain, not an accident. Skip that, skip that. We're going to say that his patient status, he's acute. This is an initial exam on him, and we're going to say that his prognosis looks good. We're going to come out of here under progress. We can't do progress since you just started. We're going to go under plan. We're going to go under examination plan. We're going to introduce the treatment. We're going to say we're going to treat him at, let's say, twice a week for 2 weeks. And we're going to do 2 units of physical therapy per visit, 2 units of massage per visit. And from there, we're going to say the rationale for physical therapy, why we're doing heat, why we're doing muscle stim, why we're doing massage. We're going to come out of this and we're going to go under our goals. We'll get the goals later. Let's go over the daily notes. Today we actually did treat the person. So we gave him an examination, adjustment, muscle stim, and heat. And from there we're going to say that the manipulations were performed. Manipulations were performed at Gonstead, C1, C2 on the right. We're also going to treat this person with the Thompson technique as a prone, right hip there, and we're going to say that we did a side posture Gonstead for L5 on the right. From there we're going to come out of physical therapy. Physical therapy was done, muscle stim and heat for 15 minutes, lateral to L4, and we did that prone, and we did that before the adjustment. Return. Get out of here. We're also going to give him a work restriction of no work for, I don't know, today through the next 2 days. And that's just work restriction. And then afterwards, we're going to put him on light duty for 2 days for a month of no standing or sitting more than 6 hours per day. And that's it. So we have a treatment plan, we have the treatment notes, we have what was adjusted, we have why we adjust them, we have work excused, no work, we have light duty, we have our analytical findings as our prognosis, our status, our diagnosis, we have our objective findings as being his gait, the patient's vital signs, his review of systems, his orthopedic test, his reflexes, didn't do any muscle testing on him, his visual range of motion, where the pain was, his palpation findings, where the muscle spasms were, what we're sending him out for x-rays, and then again under his subjective findings, smoking history, we have his medication. He's going to give us a list of history, general health, we have his past medical history, the etiology, the palliative, and the aggravating factors, what they're here for, and that's the exam. We're going to save this, and from there we can actually go in, enter a diagnosis, we can take the charges, remove all charges, and then from here we're simply going to say for this patient we did a adjustment 3, actually it was a 2 view on him, let's take the 3 view out. Yes, and for therapy we did muscle stem and heat, so we're going to go under muscle stem and heat. We take this and we're going to say that we only did this over the low back, and that is saved, and we're going to post the charges. From here we have our diagnoses. I'll leave these diagnoses in, and then from there we had any pictures, we can put down contraindication factors, treatment plans, or alerts for this individual. We can put a listings over here for them also, but we're not going to have to do that on this person, and we are done.